To chair this session, we invite Dr. P. Dharmarajan and Dr. K. Shanmugam to chair the session, please.
I think first we thank the organizers for providing a scientific feast both in the advanced learning and also the common practical learning also in diabetes mellitus. Now this topic is mostly practitioner oriented. That is most important. All the three topics we got three eminent speakers, Dr. Aravinda and you got Dr. A. Shanmugam and Dr. L. Srinivasamurthy. We'll be talking about hypoglycemia in clinical challenges in diabetic care, choosing the right oral anti-diabetic agents in the current scenario, newer insulin scientific breakthrough beyond human insulins. I think now I invite Dr. Aravinda to talk about the hypoglycemia and clinical challenge in diabetic care. Over to you, sir.
So good afternoon, everybody. At the outset, I thank DAISICON team, Dr. Shanmugam, for making me a part of this conference and giving me an important topic, that is hypoglycemia, a clinical challenge. So first of all, greetings to all of you from Bangalore. So these are the table of contents I will be speaking about. So hypoglycemia, one of the most difficult aspects of diabetes management and is most neglected also. Most of the time we don't discuss here. So that is the reason this topic is very apt in today's conference. So any abnormally low plasma glucose concentration that exposes the subject to potential harm with a proposed threshold plasma glucose value less than 70 milligram per deciliter, that is less than 3.9 millimoles per liter. So classification of hypoglycemia, there are level 1, level 2 and level 3. Level 1 is when the glucose is less than 70, more than 54. Level 2 is glucose less than 54. Level 3 is a severe event characterized by altered mental and or physical status requiring assistance for the treatment of hypoglycemia. So, if you see the glycemic threshold for the secretions of counter-regulatory hormones, you can see from 4.6 millimoles, all these things happens till less than 1.5 millimoles. That is, if you make it into 18, that will be milligram. So, severe neuroglycopenia, reduced conscious level, convulsions and coma. So, these are the various thresholds for hypoglycemia. If you take the prevalence of hypoglycemia, several large-scale clinical trials have demonstrated the incidence and prevalence of hypoglycemia in patients with both type 1 as well as type 2 diabetes. The rates of severe hypoglycemia are more common among older adults and those with chronic conditions such as CKD, CVD, heart failure, depression and higher HbA1c levels, as well as among those who are on insulin or taking secretagogues. You can see the incidence on the right hand side. In type 2 diabetes it is 0 to 73 episodes. In type 1 diabetes it is 62 to 320 episodes. So learning from DCCT trial, that is diabetes control and complication trial, there are more than 1,000 episodes of loss of consciousness associated with hypo. Even with treatment, there are reported cases of long-standing severe hypoglycemia leading to transient and even permanent cerebral damage. Hypoglycemia that is not reversed can progress from lethargy to coma and ultimately to death. So a percentage of severe hypoglycemic events in various studies like ACCORD, you can see it is 16.2%. In the middle you can see advanced, it was 2.7%. In VADT it is 21%. So increased mortality has been observed in a randomized controlled trials during more aggressive compared with the less aggressive glucose lowering therapy. What does it say? Depends, like be appropriate, individualize your treatment. You can't be very aggressive in a 75-year-old gentleman. You can be aggressive in a 30-year-old gentleman so that we can prevent the hypoglycemia. The risk factors and clinical presentation, you can see there are conventional risk factors like insulin or insulin secretagogue. Doses are excessive, ill-timed and are of the wrong type. Second one, exogenous glucose delivery is decreased. Following missed meals and during the overnight fast with gastroparesis or celiac disease. Glucose utilization and sensitivity to insulin are increased, like as during or shortly after exercise, in the middle of the night, following weight loss or improved glycemic control. I'm sure like many of the patients become over aggressive that suddenly they start walking like 5 to 10 kilometers, which they were not doing earlier. Suddenly they start doing over dieting, and all those things can lead to hypoglycemia. Next is endogenous glucose production is decreased as following alcohol ingestion or in liver failure. Next is as in renal failure, the insulin clearance is decreased, and last but not the least is the classical diabetes autonomic neuropathy. So other risk factors like advanced age, tight glycemic control, renal insufficiency, pregnancy, multiple diabetic medication, low diabetes knowledge, type 1 diabetes, insulin dependent type 2 diabetes, previous hypoglycemia. Putative mechanism of hypoglycemia unawareness. You can see from the top, the recurrent hypoglycemia leads to diminished autonomic response to hypoglycemia, leading to reduced sweating, part of glucagon production under autonomic control reduced, absence of palpitations, reduced production of catecholamines, and absence of tremors. So the mechanism by which hypoglycemia may affect cardiovascular event, very important. Why we are so much of, why we must be worried about hypoglycemia? You can see from the center, hypoglycemia, if the patient develops hypoglycemia, it leads to inflammation, leading to increased CRP, increased VEGF, increased interleukin 6. On the right hand side, hypoglycemia leads to endothelial dysfunction. On the bottom, it leads to sympathoadrenal response, that is increased adrenaline, leading to rhythm abnormalities, very important, and hemodynamic changes like increased contractility on increased heart workload. On the left hand side, you can see it leads to coagulation abnormalities. So what are the precipitants? Drugs like insulin and insulin secretagogues, others like sibenzolin and gatifloxin, pentamidine like quinine and indomethacin. Physiological diabetic complications like gastroparesis, and factitious like misuse of insulin or excessive alcohol consumption, endocrinopathy and malabsorption, autoimmune condition like insulin autoimmune syndrome. Most important, most neglected is psychological and psychosocial, that is fear of hypo or hyperglycemia, denial, depression, mental illness, and cognitive impairment. We know all the signs and symptoms of hypoglycemia. Many of us would have been experienced without being diabetic when we are hungry, like pallor, diaphoresis, tachycardia, blurred vision, elevated blood pressure, palpitation, paresthesia, difficulty concentration. So if some of you are hungry, you are not able to concentrate what I am talking today. Hypothermia, weakness, warmth, hunger, fatigue, motor impairment, slurred speech, seizure, loss of consciousness, emotional ability. If you are angered, that means you are hypoglycemia, chances are there. Giddiness, tense, anxiety, irritability, feeling down. All these symptoms I am sure all of you would have experienced. This may be very severe in a person with diabetes who develops hypoglycemia. So the diagnostic hallmark of to identify hypoglycemia, you can see on the right hand side, it's the Whipple's triad. The low plasma glucose level, that is typically less than 70. The patient is having signs and symptoms consistent with hypoglycemia. The resolution of signs and symptoms of hypoglycemia followed an increase in plasma glucose level. So what are the preventive strategies? What does the guidelines say? You can see what does it say is the occurrence and risk for hypoglycemia should be reviewed at every encounter and investigated as indicated. We should always ask a question, did you ever had an hypo symptom? Don't worry about increasing the tablets always. You ask the patient, did you have an hypoglycemia, to assess what is happened, what exactly happened. That is very, very important. Next is like insulin treated patients with hypoglycemia unawareness, 1 level 3 hypoglycemic event or a pattern of unexplained level 2 hypoglycemia should be advised to raise their glycemic target to strictly avoid hypoglycemia, because depending upon the patient you have to set a target level, what level the patient needs, what is the glucose level you want to have in a particular patient. That is very important. It's not like everybody should have a strict control. It depends upon the individual and the associated comorbidity. So because older adults with diabetes have a greater risk of hypoglycemia than the younger adults, episodes of hypo should be ascertained and addressed at routine visits. For older adults with type 1 diabetes, CGM should be considered to reduce the hypoglycemia. So what are the management strategies? How do you do this? So it depends upon the conscious state and the degree of cooperation of the patient. 5 to 15 grams of fast-acting oral carbohydrates like sugar lumps, dextrosol or biscuits or milk. Then take quickly absorbed carbohydrates such as half glass of juice, jelly beans, honey, sugar, the glucose that contains 15 grams of carbohydrates. Then follow up with more slowly absorbed carbohydrates such as sandwich, biscuits, a glass of milk, a piece of fruit. Retest the blood glucose level after 15 minutes. If not improving, then you can start the patient on glucagon, which is bit of availability issue is there. I'm sure in a diabetic patients, in a diabetic clinic, in a diabetic setup, this should be having in their pharmacy. Can be administered by a relatives or an ambulance crew. The response to this is slower than IV dextrose, need 7 to 10 minutes until the normal mental status. Will not work with alcoholics, elderly and depleted glycogen store. So recognizing and looking at them is very important. If not, the next step is 10% glucose solution, that is 50 ml intravenous. If not, we can go up to glucose 50% also. The last but not the least, where we use less, one of the important thing is octreotide, that is the synthetic analog of somatostatin. It inhibits the release of insulin. It is used in treatment of sulfonylurea-induced hypoglycemia. Only consider if it doesn't respond to dextrose. Warning, what is the important warning? Persistent of an altered conscious level suggests an underlying pathology, like it may be a stroke, it may be cerebral edema. So we need to maintain a plasma glucose of 7 to 11. Contact ICU and treat accordingly, do the further investigation to rule out other cerebral causes. So 90% of the patients fully recover in 20 minutes. When hypoglycemia cause is identified and fully corrected, patient can be discharged after observation at an emergency department and with appropriate follow-up. So arrange a follow-up having considered the following. Why did this episode occur? Is there any recent change of regimes, drugs, alcohol, etc.? Is the patient developing hypo-unawareness or autonomic dysfunction? So be vigilant. Intensive diabetic management, that is tight glycemic control, reduces long-term complication but increases hypo risk and reduces a person's quality of life. Substance abuse, always ask about the other drugs and other alcohol consumption. Impaired renal and liver function, weight loss, empty nest syndrome, that is alone and intelligent, attention-seeking syndrome. Patient with psychiatric issues, depression, mood swings, coronary artery disease and infection, all this has to be asked if the person has developed symptoms of hypoglycemia. If you take the recommendation in older adults with type 2 diabetes at increased risk of hypoglycemia, medication classes with low risk of hypoglycemia are preferred. Over-treatment of diabetes is common in older adults and should be avoided. De-intensification or simplification of complex regime is recommended to reduce the risk of hypoglycemia and polypharmacy if it can be achieved with an individualized A1C target. Considers cost of care and insurance coverage rules when developing treatment plans in order to reduce the risk of cost-related non-adherence. So ladies and gentlemen, the take-home message is the threat of hypoglycemia is one barrier to providing optimal glycemic control in the inpatient setting. Prevention is key in ensuring patient safety. Identifying risk factor, implementing protocols, avoiding traditional sliding scale insulin regimen, which is very important, and changing unsafe prescribing behaviors or ways to avoid severe hypoglycemic events. Reviewing hypoglycemic signs and symptoms with an entire inpatient team, including patients and their significant others, allows for an early detection and treatment. Establishing and publishing a simple treatment protocol affords prompt action to appropriately treat various stages of hypoglycemia. Always in your consultation, whenever the patient comes for follow-up, discuss with the patient, take the history from the patient as well as the relatives, whether they had any symptoms of hypoglycemia, ask question, revise the treatment, do the needful. In the future, you can avoid hypoglycemia for the better care of our diabetic patients. Thank you, ladies and gentlemen, for the patience hearing.
Thank you, sir. Very simplified version of the whole aspect of hypoglycemia you have covered. I think everyone would have experienced a lot of similar episodes and also how they have recovered. But most important, public education is very, very important. The family education is very, very important. And also in the educational institute, people with the type 1 diabetes, I think teachers also sometimes they have to get educated. It's very, very important. Thank you, sir. Very nice, sir.
Thank you, sir. Thank you.
So we'll move on to the next topic of the session. Will be delivered by Dr. A. Shanmugam, our former President HOD of KMC, and the Organizing Secretary of DAISICON2025, Dr. Shanmugam. He'll be talking on choosing the right oral anti-diabetic agent in the current scenario, a practically oriented topic.
Thank you, Chairperson. At the outset, I'd like to thank our organizing chairman, Rajendran sir, and scientific chairman, Anand Moses sir, for the opportunity given to me. This is a quite interesting and clinically oriented topic. I'm going to discuss another 15 minutes, choosing the right oral anti-diabetic agents in the current scenario. So there is no conflict of interest for this session. And to start with, we have a patient's 46 years old male, businessman, recently detected as diabetes, had a family history, complication family history also there, BMI of 30, fasting postprandial is elevated, HbA1c is 8.7, and lipids also elevated and not on any medications. How do you go with that? What is the treatment regime would you offer to this patient? This is a common scenario we come across in our clinical setup. So there are two things are not changeable. It is diabetes is a progressive disease. Even though we have some drugs to halt the progression, still it is a progressive disease. So as insulin resistance stays over a period of time, the insulin deficiency per year, almost 2 to 8% insulin deficiency, beta cell decreases happen in over a period of time. And we understand diabetes with some of the good papers, particularly the basic papers. UKPDS, we learned about bringing down HbA1c is most important. The UKPDS follow-up data, we understood that not only bringing down the sugar, first 5 years of diabetes management is most important. The ACCARD tell us about don't induce hypoglycemia. If you induce hypoglycemia, definitely will have harm to the patient. The cardiovascular mortality goes high. In ACCARD, advanced also advanced VADT inform us, particularly in elderly population, if you are treating that, not to induce hypoglycemia, and very slow titration of blood glucose control is mostly beneficial to that. And the last and the most important is the cardiovascular outcome trials. We have so many cardiovascular outcome trials. For last couple of years, we have good number of data with the cardiovascular outcome trials. We have used so many drugs currently available in type 2 diabetic population, including GLP-1 receptor agonists, SGLT2 and DPP4 inhibitors, and sulfonylureas and the metformin as well. So overall, all these drugs are hyperglycemic villains. We all know that there are variable HbA1c reduction has been shown, and various fasting, hypoglycemia risk, weight change, everything has been known. It has been discussed in the various forums. My flow is here, which is Uttama villain, which is the best drug to choose in the current scenario. So before going to that, this cardiovascular outcome trials give us so much information about each and individual molecule, which molecule has to be chosen at what point of time, which molecule should not be used at what point of time. So if you take cardiovascular outcome trials with the SGLT2 inhibitors shown that it is a class effect in reducing hospitalization for heart failure, particularly in type 2 diabetic patients. Even in non-diabetic patients, in the heart failure related trials, non-diabetic patients, irrespective of ejection fraction, the SGLT2 inhibitors can able to reduce primary endpoints. Significant reduction is there. So this is one sample I'm putting here. So all the SGLT2 inhibitors will be beneficial in heart failure irrespective of diabetes. Having said that, let us see about individual drug. What is the potential risk when you should not use this drug, when you should use it caution, and what are the benefits? You should not miss the benefit of each and every drug. Such a way that we start with the SGLT2 inhibitors. SGLT2 inhibitors, we all know that it can cause euglycemic ketoacidosis, mycotic genital fungal infection, but you should not miss this drug in terms of weight loss. If you want weight loss, BP reduction, if you want cardiovascular benefit and heart failure benefit, you should not miss this drug. And renal benefit also shown with this drug. And GLP-1 receptor agonists will be beneficial in significant weight loss and cardiovascular benefit. Those patients having atherosclerotic heart risk factors, this drug will have shown data that this is one of the beneficial drug if a patient have multiple risk factors, particularly atherosclerotic cardiovascular disease. Obviously, this won't cause hypoglycemia. And DPP-4 inhibitors, we all know that it is also well tolerated, particularly well suitable drug for elderly diabetic. If you want to have weight neutral, at the same time without inducing hypoglycemia, this DPP-4 inhibitor is still a relevant drug in the current scenario. This is sulfonylurea. We have used this drug almost more than 4 decades or 5 decades. We know that sulfonylurea can cause weight gain and hypoglycemia, but it can, with the latest drug, we can able to avoid that also. But cost is the most beneficial effect because of in terms of sulfonylurea. And glycemic efficacy, we have significant HbA1c reduction and the availability. It is available everywhere, so patient will not have a problem in getting this drug. TCDs, obviously, it will be useful in MASH, steatohepatitis, stroke patients, and it won't induce hypoglycemia. At the same time, we should be cautious about weight gain and diabetic retinopathy and sodium water retention, where it become a problem in heart failure patients. Alpha glucosidase inhibitors quite useful for postprandial control and high carbohydrate load whenever patient, particularly Indian setup, we do use more of carbohydrate. This is a quite useful drug. Insulin, obviously, it is a good drug. It is always a rescue therapy. When none other drug works, insulin always works. So it is a good drug for glycemic efficacy. It also addresses glucotoxicity, and it always useful in acute conditions like any septicemia, DKA, hyperglycemic osmolar coma, all our diabetic emergencies, we do use insulin. And the last but not the least, the metformin. If you see here, the contraindication, the cautions, the red light, yellow light is very limited. So we should not use this drug only in CKD less than EGFR less than 30, in case of sepsis or ICU setup, or if a patient knows GI intolerance, particularly for metformin, we should not use, but lactic acidosis is quite rare. It is a CV safe drug as per UKPDS data. It can combine with any other drug, and cost is quite low, and availability is everywhere. It is weight neutral. Some patients may lose 1 or 2 kg weight loss, and another benefit will be an anti-cancer benefit. None other anti-diabetic drug has shown this benefit, but this is the only drug shown that metformin. That is why we have used this metformin as a gold standard. But even though nowadays we have much more debate whether to use metformin as a first line or not, but still it is a valid drug in type 2 diabetes management. So after starting metformin, this is a truly $1 million question is, for a common clinical scenario, what to choose next, whether to go for sulfonylureas, DPP-4 inhibitors, GLP-1 receptor agonists, or SGLT2 inhibitors. So this is the data showing that after metformin, if you add pioglitazone, what will happen? If you add DPP-4 inhibitors, if you add sulfonylurea, what will happen? Almost all the drugs will have same HbA1c reduction. So in terms of glycemic efficacy, all the drugs are similar. So all the drugs are similar, then how do you choose the drug? What is the best way to choose a drug? Individualization is the key. In terms of individualization, what do you mean by individualization? We know the recommendations, ADA, ASD, American Association of Clinical Endocrinology. We know that so many trials, whatever trials have shown that, and safety, whatever we have discussed it, and comorbid conditions we have to consider, and particularly the cost. So the choosing the right OHA based upon the 5 parameters. But not only the individual OHA will not help. Whatever OHA you choose, it must address the pathophysiology. We all know that diabetes is an omnious octate. It has 8 defects. The main problem with the diabetes will be hyperglycemia. Putting all together into a puzzle, center point as a hyperglycemia, and each term into puzzle, we look into it, each drug, how it works. So metformin addresses 1 out of 8 puzzle, sulfonylureas addresses 2 out of 8, thiazolidine 4 out of 8, DPP-4 4 out of 8, GLP-1 receptor agonist 6 out of 8, SGLT2 2 out of 8. None of the drug will address all the 8 defects in the puzzle of pathophysiology of type 2 diabetes mellitus. So whether to choose with the monotherapy or dual therapy, which will scores over in type 2 diabetes management. There is so much data available that. So combination therapy, particularly early combination therapy, will be the best way of managing diabetes rather than going with monotherapy, then you add on a second drug, then you add a third drug. That is a well-documented and verified trial that there is where L-dagliptin and metformin has been used. The combination of early combination of TPP4 and metformin have a significant HbA1c reduction than sequential add-on. This is the same thing true with triple combination with EDIC trial, which shown that metformin, pioglitazone, and GLP-1 receptor agonist has been studied here. The early combination of three drugs than more beneficial in terms of HbA1c reduction, durability than with sequential add-on. The same thing with duration 8 trial with there they have used DAPA plus GLP-1 receptor agonist and metformin. So all the trials, either dual or triple combination, if you want to address diabetic patients, you go with aggressive management or the early management so that we can have a better control and durability also. So the ideal combination which will address all the 8 puzzles defects in type 2 diabetes mellitus also, one will be if you're combining with TCDs, GLP-1 receptor agonist and SGLT inhibitors plus or minus with metformin, definitely this combination will address 8 out of 8, all the pathophysiological defects has been addressed with this combination. So having said that, why we need to go with early combination therapy? It addresses multiple pathophysiological defects, it targets more rapid bring down the sugar, it also very durable, and it also preserves beta cells, and it improves compliance part. So it also shown that the treatment failure, the secondary treatment failure will be reduced significantly if you go with this early combination therapy. So having said that, molecule we had understood about which molecule when to use the combination therapy, now the main focus is whether to focus on glucose-centric way or whether to focus on cardio-renal centric way, which is the best way of diabetes treating. So approach to diabetes treatment has been evolved over a period of time. Before I joined in a diabetology department, during my postgraduate days, before 2000, if you bring down HbA1c less than 7, you are doing good for the patient. With the evidence with Euclipides, DCCT and Kumamoto. In 2000 to 2010, with the data from Euclipides Legacy, Advance and Accord, we understood that we need to bring down the HbA1c, at the same time early good glycemic control, at the same time you should not induce hypoglycemia so that you should not harm to the patient. In 2010 to 2020, with the CVOT trials from DPP4 inhibitors and sub-studies SUNO trial, which tell us not only bring down the HbA1c, you should individualize HbA1c. So if you are dealing with the elder people, you are dealing with the elder with the cardiovascular disease, you should not induce hypoglycemia. With the young and energetic who are having long duration of life, we should focus on HbA1c of less than 6.5. The current scenario, we are focusing on cardio-renal safety with the help of cardiovascular trials, particularly heart failure trials and GLP-1 receptor cardiovascular outcome trials. We are focusing on cardio-renal safety. Having said that, the most main aim of management will be comprehensive cardiovascular risk reduction, and renal risk reduction must be the main focus of therapy. Why we do treat diabetes? Our patients should not end up in complications, particularly heart disease. They will not die of heart disease, or they will not end up in nephropathy. They need dialysis. This is the main focus of diabetes management. So whatever the patient we have, assess the patient profile and comorbidities. So look for cardiovascular disease and look for kidney function, particularly EGFR. We consider weight, whether we need to bring down the weight or not, or hypoglycemic risk, whether the hypoglycemia will harm the patient or not, and patient preferences. I should not choose this drug, GLP-1 receptor agonist or costly one, which a patient cannot able to afford it. So the patient preferences, all these things has to be considered. And after choosing a drug, and we should consider that whether this drug has been cardiovascular and renal benefit, whether this drug will not harm heart or should not hurt the kidney as well. So, and considering all these parameters, a drug and the cardiovascular renal benefit, you should consider about cost benefit and adherence factors. The cost is a major factor in terms of adherence. All these things should consider. Based upon this only, this ADA has given guideline that if you are going with the dealing with atherosclerotic heart disease patients, particularly atherosclerotic risk factors, go with GLP-1 receptor agonist. If you are dealing with heart failure, preferable drug will be SGL2 inhibitors. If you are dealing with CKD, again the SGL2 inhibitors will be preferable drug. Or if you are looking into weight reduction, GLP-1 receptor agonist. If you are dealing with young diabetic without heart disease, without much risk factors, still metformin will be the first line of treatment for most of our type 2 diabetic patients. The ACE guidelines also suggest that, but it is quite different, that if its HbA1c is less than 7.5, go with monotherapy. If it is 7.5 to 9, go with dual or triple therapy. Or if it is more than 9, still insulin has a role in, if a patient have asthmatic symptoms, you should go with insulin. This is the Italian guideline. I think this is quite useful for our primary care physicians. This is easy to follow it. No cardiovascular event, no heart failure. eGFR is more than 60, go with metformin. If at all you want to add a drug, go with SGL2 or GLP-1 receptor agonist or DPP-4 inhibitors, whatever you want. Then add pios, acarbose or insulin or sulfonylureas. Then if you are having previous cardiovascular events but no heart failure, still metformin, GLP-1 receptor agonist or DPP-4 receptors or SGL2 will be stable. If a patient is having some point of heart failure, you should use SGL2 inhibitors. You should not miss this patient without, treat the patient without using SGL2 inhibitors. This is about Italian guidelines. This is quite useful for primary care physicians. So to conclude that, choosing a right oral diabetic drug will be always, if a patient doesn't have heart failure or severe risk factors for heart diseases, always start with metformin and prioritize a cardiorenal protection and individualized therapy in terms of cost, efficacy and HbA1c targets, and empower through education. This is the most important part. Whatever we do, we should educate about patients, about complications, all these things, and innovations. There are so many tools are available now, particularly TAR, ambulatory glucose monitoring, self-monitoring of blood glucose, all these things integrated into a patient care, and whenever possible, we combine early. So early combination therapy will have a better way of management. So remember, is the best medication is that one addresses pathophysiology and patient safety and patient specific need, and the same time patient can able to afford, so that the patient can compliance will be good for this treatment part. So this case scenario, what will be the best drug? So, know the contraindication for each and every drug, respect the indications, and rely on the evidences. If you, whatever medicines you choose, if you follow these three rules, definitely whatever drug you choose, it will be the best drug for your patients. Thank you for patiently listening.
Thank you, Dr. Samir, for that excellent talk on the subject, choosing right oral antidiabetics. And the way that you have prepared the slides and the presentation was really excellent. So I think all of you will agree with what you was talking on, and we'll have a discussion on the practical aspects of choosing the drug at the end of the session. So we'll move on to the next topic, will be by Dr. L. Srinivasamurthy. He'll be talking on the topic on newer insulins, scientific breakthrough beyond human insulins.
So I think pre-lunch Shanmugam எல்லாருமே வச்சுட்டு இன்சுலின் வச்சு ஹைப்போகிளைசிமியான்னு பேசிட்டு இருக்காரு. ஸோ குட் ஆஃப்டர்நூன், வணக்கம். மேலே இருக்கிற சண்முக சார்த்துக்கு, கீழே இருக்கிற சண்முக சார்த்துக்கு சேர்த்து ஐ அக்னாலேஜ் presence of SSL sir and other seniors who are here, Sheshaya sir. And I'm going to talk about the advantages what we get from our newer insulins. That's what I'm going to do for, say, next 15 minutes. And slide changer. Yeah. Thank you. So, going to talk about the scientific breakthrough beyond human insulins. That is what we're going to discuss, and these are my disclosures, of course, and I've been contracted for this lecture. And we know last 100 years, the historical landscape which is clearly shown, the insulin development has come a long way, and we are definitely eating those fruits which our great people have done in these last 100 years. And of course, during these advancements in insulin, which is being a continuous journey, we have faced a lot of problems with animal insulins. I'm sure many of the seniors would have experienced this about the immunogenicity, limited availability, impurities in the insulins, and of course, late 80s, we got this human insulins, which talked about the low immunogenicity, high scalability, and highly purified insulins we started getting and made our life much easier. Conventional insulin landscape, you can see about the short-acting, intermediate, and the human premix insulin, which is there as a duration of 11 to 20 hours, which again is one of the highest selling products in our country. So the conventional insulins always add limitations in our routine clinical practice with a variable absorption, the slower onset, the pronounced peaks, the peaks and troughs ratio, and of course high risk of hypoglycemia, low predictability or intraday variability, which I'm going to talk about in our newer insulins, and of course delayed action, flexibility, rigid dosing schedule, and more dose requirement. These were all the factors which were inhibiting or delaying our insulinization in our country. The perennial challenges with insulins in general are about their efficacy, the belief, the wrong belief many patients and the treating physicians have about the inertia, the conflicting with the lifestyle, hypoglycemia, restriction to perform the daily activities. So these were all some of the factors when we initiate insulin, we tend to have a backstep because of these challenges which we face with insulin. So the main agenda would be revolving around the two insulins, which is one is a premix analog, another one is a long-acting basal insulin. Now let's look at a case scenario. Suresh, 54 years, businessman, BMI 24, diabetic 11 years, not been exercising like many of our patients, and look at the A1C. He's 11-year-old diabetic and having a A1C of 10.3%, and FBS, PPBS, and the treatment history, literally he's got all that which Shanmugam was alluding earlier, and including a premix insulin of 8 and 10 units, and of course, patient complaints of frequent hypoglycemia, especially the nighttime hypoglycemias, early morning hypoglycemias, which most of us face difficult to treat in routine clinical practice, and he feels the quality of life is affected. Definitely it will be affected because of repeated hypoglycemia, binge eating, etc. Now let's look at the evolution of these premix insulins. We had this NPH and regular human insulins, which many of them used to draw from two vials and mix it, shake it, etc. The resuspension part used to be a headache. And then came about the biphasic analog insulins, which made life definitely better. But now we have this degludec aspart combination with a 70-30 ratio, which is ready for immediate use. There is no resuspension required. And that's the convenience now we have with the lesser incidences of hypoglycemia, especially the nocturnal hypoglycemias. So the conventional premix insulins add these limitations, includes the glycemic variability, the incomplete coverage over 24 hours, need for resuspension every time they take out from a refrigerator or from this, and a shoulder effect. The shoulder effect is nothing but the protamine, non-protamine insulins, which are now combined and given a prick in the subcutaneous tissue. The short-acting insulin is prolonged. The action of the short-acting insulin is prolonged, eventually ending up with hypoglycemia. So that's what is the shoulder effect, which we used to face, and many of us did not know what to do because it's a premix. So we could not really counter those hypoglycemic, repeated hypoglycemia episodes. So this co-formulation which has come up, how is it? It's about two unique insulins in a single formulation with a simple insulin regimen, fewer pricks, and greater flexibility in the dosing time. That's the advantage what you get, where there is no need of resuspension, no interaction, and it has got a retention of individual properties separately. That is, if you see ultra long acting degludec, short acting aspart combined, and it is a soluble insulin analog. So how does it work? In this formulation, they stay separately, and when you prick in the subcutaneous tissue, the IDEG dihexamers and the high hexamers, they are injected into the subcutaneous tissue. The phenol, which is binding these two, quickly dissolves, and the IDEG dihexamers link up single side chain, and they make a longer multi-hexamers. And in the subcutaneous deposit, the IAS monomers are released immediately into the circulation, whereas because the zinc, it diffuses slowly and causing the IDEG hexamers to disassemble very slowly. They become monomers again and they get. This is how it happens in the subcutaneous tissue. That's how you have the action of rapid versus the degludec, which is slow releasing. So at switch, it has got improved efficacy, lower dose requirement, reduced pricks, that is the burden, and improved safety. And that's what the evidence will quickly look at. This is switch from older premix to the Rhizodec, wherein you can see at the end of 3 months, 6 months, the p-values you can see in the last are significant. That means the significant improvement in all the glycemic parameters with respect to the A1C, the FBSP, PBS are clearly depicted here with respect to at the end of 3 months and at the end of 6 months also. Now, the dose reduction with Rizodac when you're switching from a premix and to this is, you can see 0.57 units per kg. At the end of 3 months and 6 months, you can see about 0.49 units reduction. That means that much cost saving happens. Many of us, it's out of pocket market in the country, so we always discuss about the cost implications when we switch over to the newer insulin. This is how the cost benefits are transferred to the patient. Now, more than that, remember, you get the advantages of lesser hypoglycemia episodes. That again, the cost is transferred and it is definitely saved for the patients. And this is what happens with the dose reduction when you switch a low mix ratio like premix 3070 or Lispro 2575 or Aspart 3070, you get a degludec dose reduction by 21% at the end of 3 months and 19% at the end of 6 months. And that's the beauty of these molecules, which not only reduces the cost burden, the hypoglycemia, the requirement of the total dose also comes down. And whenever insulin, we talk about the safety profile. Look at this confirmed hypoglycemias, which are significant lower risk of confirmed hypoglycemias with a BID dosage of Rizodac and BID of Aspart, by Asp, that is your no mix. And look at in the insulin naive patients, first time when they are started, you have a reduction of 54% of lower confirmed hypoglycemia. That means the glucometer value less than 54 milligrams. And of course, 75% reduction of the nocturnal hypoglycemia also has been clearly documented, which is very, very clear with the Rizodac. So 75% is a big number when it comes to the clinical practice in the insulin patients. So when you switch Rizodac from older premix insulins, you have a better efficaciousness, lower dose requirement, lower pricks, and improved safety. That is what we look at like an ideal insulin combination, and that is what you get. So this patient who was having 10.3 A1C was switched over to Rizodac 10 units with a major meal, and that's the advantage. You can give it OD or a BID, and he achieved the target without hypoglycemic episodes. Now let's look at the Tresiba's long-acting potential for diabetes, harnessing Tresiba. Of course, Tresiba, I am little emotionally connected because that was the first US FDA inspection at my center I faced was for the Tresiba way back in 2012. Before it came into the market, that was one of the approval inspections by US FDA at my center in Bangalore. So let's look at one of the teacher who is 55 years old and got a BMI of 23.8. And you can see he's a 7-year-old diabetic. He's got a family history of diabetes and exercise been regular, though he's a teacher. He's not disciplined. And of course, A1C of 9.8%. And the treatment, you can see, the metformin, glimi, pio, good combination, as Shanmugam was alluding earlier, but he's got NPH insulin, 8 units twice a day, and he faces difficulty in injections. And of course, the CGM, he shows that the high variability with respect to us. Now, 2025 ADA standard of care clearly talks about the basal insulin as the most convenient insulin initiation option. That is what it says. It is the most convenient. Now, whenever we look for a basal insulin, we need these characteristics: a flat glucose lowering profile, long duration of action, minimal variability, and lesser risk of hypoglycemia. This is what we look at in any ideal insulin. Now, you see this slide which talks about the perfection which is continued through the progressive paths with this molecules over a period of time, and you can see the half-life and variability, how it comes down with the degludec. The variability is low and the half-life is extended to 25 hours. So second generation or ultra-long-acting basal insulins, what we call, have this. So the unmet needs with first generation and the conventional insulins, which are not truly once daily, they have a higher variability, they have a fixed time dosing. For example, you see glargine, it says every day, same time in the evening. But that is lack of the dosing flexibility, which makes life very difficult for most of our patients because you can't stick on to the same time of the night every day, and not truly peakless, though we call it peakless. And look at the Tresiba's flat action profile. The PKPD studies clearly shows it has got a flat profile across 24 hours. And look at the within day, that is intraday variability. The total glucose lowering effect is evenly distributed with your degludec versus glargine U100, which you can see that stepwise kind of a tapering after a few hours. So the lower day-to-day variability, you can see again, it is better with Tresiba, which is in the dark green color. And of course, glycemic variability is another big challenge we face in clinical practice. And glargine U100, based on the pH, it precipitates in the subcutaneous, so there is a slow dilution to monomers. And that is taken away by your degludec, and the formulations that do not precipitate after injections have a lower day-to-day intravariability. That's what you should choose when you're choosing it. And of course, the A1C reduction, this is called Switch Pro trial, the treatment difference reached statistical significance in favor of Tresiba over glargine U100. And of course, it shows greater FBS reduction. It has got consistently shown statistically significant greater FBS reduction in treat to target trials with glargine U100. And you can see all the trials which are there. And the Switch Pro trial is something different, where they looked at the superiority of Tresiba over glargine U100 with a TIR, of course, with a CGM. So look at the estimated treatment difference, which is statistically significant by 1.43%, which amounts to about 20 minutes per day in favor of Tresiba. And of course, it has got lower rates of hypoglycemia risk in the form of overall hypoglycemia to the tune of 30%. Severe hypoglycemia. What is severe hypoglycemia in clinical trial? Less than 54, and you require assistance to treat yourself. So that is come down by 51%, and the nocturnal hypoglycemia by 53%. And that's what it has consistently proven, that the hypo benefits with Tresiba or glargine across RCTs, across real world studies in more than 16,000 patients with diabetes have been proven beyond doubt. And of course, you have a dose flexibility. As I said, glargine, if you see the insert, it says every day, same time. So that means 8 p.m. we usually tend to write for glargine U100. Here, it can be, this Sunday night he forgets, he can take it on Monday morning or Monday evening also. That flexibility is there for patients. Of course, we don't recommend them to take it like that, but somebody who reaches home late, he can take it at 9 p.m. or 10 p.m. instead of 8 p.m. That's the flexibility we have. And of course, it can be used across diverse populations, as you can see, starting from pregnancy to the pediatrics, to the elderly, special populations, what we call renal or hepatic impairment, and also in hospitalized patients. And of course, how do you initiate? You just start with your 10 units Tresiba, and switch from other insulins is usually 1:1, except in the basal BID or the glargine U300, you need to cut down the dose of Tresiba by 20%. Of course, we have this app for patients, especially a dose guidance app, which you just have to feed in the FBS and the insulin dosage. You get those on a daily basis, and you and your doctor can see that. So Ramesh, who's a teacher, achieved his A1C target without the glycemic variability. Now he's able to control over his injection timings, because you have that flexibility for him to have it, apart from metformin, Glimi, and EMPA is continuing, which is supposed to be there. So to summarize, Ryzodac and Tresiba are designed for greater efficacy, improved safety, and better convenience versus conventional insulins. And we have a better A1C reduction with a target achievement, and lower risk of overall and nocturnal hypoglycemia, which is the key, and lesser glycemic variability. And we have a wider window of dosing flexibility and improved quality of life. That's what we get from our newer insulins versus conventional insulins. And of course, to finalize, new generation insulins offer improved PKPD, improved quality of life, convenience, low risk of hypoglycemia, low risk of nocturnal hypoglycemia, faster onset, and the offset of action is not seen, less injection breaks, flexible dose timing, more predictable effects. Thank you very much for patient hearing.
Thank you, sir. You made the complex topic very simple by your animation also, and the way in which you have put the material to the audience, especially with the smiling face. Now, yesterday I told no, who is in, was always smiling. He is smiling even now. But the only factor, the prohibiting factor for the newer insulin is the cost factor. Otherwise, I think everyone will be switching over to the newer insulin. I think now I call upon the other speakers also to come to the, so that we will have a short interaction of the questions. Very relevant question, very short questions and short answers.
Rangarajan sir is ready.
Short question, short answer.
Sir, hypos are meant by insulin. Insulin is meant to produce hypos. But you must know how to titrate without producing hypos. It is like a chess game. You must know how to manipulate the coins right or left or up and down. So, if you see a patient with hypos, that means the part played by the physician is to be blamed because he or she should educate the patient when you give a vial or not a vial. Nowadays I don't give vials, I give only cartridges and explain to them in detail how to go about it, how to titrate. And every third day, I ask my patients to give me a call back. I will titrate. So in this case, in my practice, I am yet to see hypo.
Great, sir. I think great point to be taken. I
But
think
yet to see
most of us don't spend time
Sir.
when we initiate insulin. I think that's the
But
crux.
hypo was there in the exterior porcine. The porcine, so bovine insulin was there with a lot of immunogenicity, but it is not there. But as right now, the cost of escalation is there, but the cost of people earning is also more. When they can spend money for liquor, why can't they spend for their health? What prevents them? Because we are telling them it's costly. Sir, we are only putting this into their head. Whatever is best you give, I will buy. That is what the kith and kin say. So please, in forums, please don't talk about cost.
Yes, sir. What you said is correct. We should come out of the inertias. We should offer the patient what best it is.
And one more thing, sir, regarding insulins. I just want to put in the honorable forum, we in the cosmopolitan cities or big cities, we are well aware of it. What about the doctors in the periphery, sir? They hardly have time to come to a meeting like this. They have to come travel 50 to 60 minutes. Someone should sponsor them. These are some of the limiting factors. So they are little bit hesitant to take the insulin. And moreover, even if they take, they don't know how to titrate it. So this is some of the things.
Thank you, sir.
Sir, regarding hypo, sir, I would like to tell you, if a patient goes for hypo through a glibenclamide, and if you really see a hypo, it's very, very difficult to take him back. After 3 weeks or 4 weeks, he is going to go to the heaven. So this is the one thing I want to talk, sir. And
Sir, can you briefly ask a question so that they can answer?
No, I'm telling you. See, because I'm giving my inputs. I'm not asking no questions.
Okay.
No questions.
He's sharing his experience, very well
It's okay,
appreciated,
it's
sir.
okay.
Thank you.
Sir, insulin education is a must, sir. Please insist on that. When you constantly say hypoxia, the young people sitting in the bed, they get scared. They don't know whether to start or not to start. And as far as Dr. Sharma said, it is really a game you have to put in the mind and play when selecting the drugs. Yes. And sir, you said Tresiba.
Sir.
That's a bridge therapy. You give Tresiba in the night, in the morning you put it in OHA. So that's good. You need not give 2 pricks.
Correct, sir.
Okay.
Thank you. Thank you, sir. We appreciate it.
Any other questions from the forum?
Sir, this is my practical question for Dr. Aravind, sir. Most of them type 1 diabetes of 4 years, 5 years, they have severe hypoglycemic symptoms, but HbA1c is 9.5 and fasting is 200, postmortem 300. But their typical hypoglycemic symptoms, only when they take food, they become all right. That's the situation, but HbA1c is high and fasting both are high. So in this scenario, what you supposed to do?
So mainly the monitoring the food pattern, what they are taking, and educating the family members, and if possible, CGM should be very appropriate. Because we don't know when the patient is going for hypoglycemia. Typically, as you rightly pointed out, there will be hyperglycemic episode in the morning, hypoglycemic episode in the evening. It will be totally erratic and it will become a clinical challenge. So if you have an option of a CGM, if you use it, why it is happening, what is the dosage to be adjusted, which type of insulin to be given when, that would be the most ideal to prevent hypoglycemia.
Sometimes it happens in newly detected diabetes. When you have a high sugar, you give it a minor dose, the patient will develop hypoglycemosis. Hypoglycemia-like symptoms, but sugar will be quite high. That is also one scenario. Whenever patient's blood sugar is always 300, 400 plus, if you bring down 250, the patient will feel the hyposymptoms.
Actually, sir, what I had 2 patients, I reduced the dose for them. Whatever the dose 4 years, 3 years were having, I reduced the dose, become all right. But anyway, that they have to come for review. So that has a real clinical problem in treating the patient.
I think SSL sir wants to add something.
Yeah.
I think with the onset of CKD, we get the hypoglycemia. I think GPs should know that, number one. I'll share one of my case. We had a hypoglycemia in the night. 60-year-old lady brought with severe hypoglycemia. We gave intravenous glucose. The glucose came up, but she never regained the consciousness. She remained unconscious for more than 24 hours. We did MRI, all the investigations, she was perfectly all right. The second day when the nurse wanted to change the dress, she looked at the knee, the lady has separated about 78 fentanyl patches for osteoarthritis. The son has brought it. So sometimes remember, hypoglycemia can occur by people co-administrating something like DAISICON tablets. So one should remember in your practice to check for the narcotics.
Especially,
Thank you, sir.
as rightly pointed out by sir, people using anti-malaria like quinine, antibiotics like gatifloxin when given for different condition. Suddenly, everything is going on smooth, but they land up in hypoglycemia. These things, history is plays an important role. And any patient having
Even the eye drops could produce hypo. Gatifloxin eye drops could cause hypoglycemia.
Yes, sir.
Thank you.
Thank you, sir.
Thank
So
you.
1
Thank you.
o'clock, I
Thank you
think we
all.
can